Hi, everyone. My name is Vladimir, and I'm a host of this webinar and also European Solidarity Corps volunteer. I would like to welcome you to the webinar about access to treatment and care for HIV-positive migrants in Russia, Sweden, and Turkey. This webinar is arranged by Posithiva Gruppen, the biggest patient organization for HIV-positive people in Sweden. Just for you to know, we do have two beautiful functions. The first one is a function of translator. So if you need a translation from English to Swedish, please press glow button and therefore svenska. The second beautiful function that we have is a question for Q&A, questions and answers. So if you're eager to ask your question, please press Q&A button and type your question. Talking about the context of the webinar, migrants are considered to be one of the most vulnerable groups in terms of HIV and HIV-associated stigma. Due to legal aspects, due to migrant stress, differences in healthcare system, and first and foremost, intersectional stigma, migrants can experience significant difficulties in terms of starting and continuing HIV treatment, in terms of receiving proper diagnostics and any kind of care they need. I believe that this webinar will help us to know more about the diversity of contexts, about challenges and resolutions, and therefore will become insightful for creating new services, new advocacy strategies, and brighter future for HIV-positive migrants overall. And I'm going to start the narrative part of the webinar with presentation by Dmitry Korinev, a social health specialist from Fund for Prevention of Social Significant Diseases, STEPS.
Thank you. Hello.
Hello.
Just 1 second, and I'll share. Could you see it?
Yeah, perfect.
Thank you. Firstly, I'd like to say thank you. Thank you for the invitation. Secondly, I'd like to be quite briefly, and I'll start with some statistic about Russia. As you can see, more than 1,200,000 of confirmed HIV tests were done, and we know that it's just about official statistic. Real numbers much more people, because there are migrants who can be in such statistic. There are anonymous tests, rapid tests, and some other variants of diagnostics. So official number 1,000,000 and almost 200,000. In the previous year, in 2022, it was more than 80,000 of positive results also. And as we could see on these numbers, it's much more bigger than in some European countries or in some other regions. And what's interesting also, I'll say about it a little bit later, but I'll say now that almost all of them, more than half, 60%, men. We are talking about mostly men when we are talking about HIV cases in our real situation. It's official data from Federal Scientific and Methodological Center for the Prevention and Control of AIDS. It's like partly CDC. In USA, the same in Russia. On this diagram, we could see a distribution of HIV positive people. It depends on their age, and as we could also see in previous years, it's about young people. It's about people who have active working age. So it's a problem. It's a big problem for all of us, and for our economic also. I said about men that in our practice and official data shows the same. Men has more risk, and 60% of new cases is about men. But we could see on this diagram that in previous years, and especially in 2022, 72% of variants of ways of transmission HIV was about heterosexual sex conflict. So it's quite interesting, it's quite strange, and maybe not real. I mean, official statistics not the same as real situation, and we could talk about stigma also, that people who live in Russia can say, for example, that they have homosexual contacts. So it's all about heterosexual contacts in official banks. About migrants, we could see that comparing numbers of HIV positive migrants and comparing numbers of HIV positive Russian people, there is a big difference in these total numbers. And as you could see, in previous year, in 2022, was 4,200, and half of foreigners who have diagnosed HIV, and it's much more less than when we're talking about Russian people. If we're talking about absolute numbers, we could see such statistic. If we're talking about relativity, so we could see that it's a big difference between Russian who have HIV and foreigners. For sure, we could talk about absolute numbers, and we know that Russians in Russia are much more than foreigners. But in relatively, we could see the difference. Russia is one of the several countries where there are more strict, the most, I would say, not the more, the most strict rules and restrictions for HIV positive foreigners. Russia, unfortunately, has special law. Because of it, it's illegal to be a foreigner with HIV in Russia. On this slide, we could see numbers 19, but it's not correct. It's quite old data. Anyway, almost all countries which we could see right now in the same list. Yeah, still in the same list. There are two options for foreigners who come to Russia. If they are coming to Russia for applying for study or for work permission, they should do a test and some fingerprint, some other procedures in 30 days. If they don't want to work to make legal status or to study or to do something else, they have 90 days for it. Anyway, it's impossible not to do tests. It's impossible not to make any legalization process if you plan to be here. So, unfortunately, there are one variant of history. If someone who don't have Russian citizenship have HIV positive result, we are talking for sure about official positive results in official government healthcare system or clinics or laboratories, not about rapid tests, not about anonymous rooms or something like this. If they have HIV positive result, Rospotrebnadzor, it's like CDC, know about it, and Migration Department makes something. It's not like deportation. It's like a special paper. Because of it, you need to go back to your country. It's not like strict deportation. Anyway, there are two options: to go back, to come back to their country, or to stay here and be in a shadow, be illegal. So most of migrants, for sure, decided to be illegal. And we have a lot of people who we can't count. We don't know how many, who don't have any documents, who live here illegal for a year, for some months, for some weeks, for a lot of years, some of them. Anyway, if they will be discovered, they will be sent to isolation. It's like a prison where they could also spend a lot of weeks, even months, and even years. It's like a prison, a real prison. And after that, it will be deportation. Here you could see some points. Talking about it, we could say just one main idea. It's illegal to be a foreigner with HIV in Russia. For sure, there are some exceptions. There are some variants, but it's difficult. Anyway, if you are a foreigner, you are HIV positive foreigner, and you have someone like a child, parent, or wife, husband, you could try to apply for citizenship, but it's really complicated. It's possible, but complicated. You need to do a lot of work, to have a lot of papers. It takes a lot of time. Anyway, it's possible, but it's about small number of situations and about people. Yeah, mostly people can't legalize anyway. So they have a lot of problems, a lot of stigma, a lot of fears, a lot of problems with their health. And only one resource that we have, it's non-government organizations, NGOs, who help some non-official opportunities, some non-official variants. Blue color, you could see the phrase about that migrants mostly become HIV positive in Russia. There are some studies, you could see the link here, which shows that most of migrants have infection here, and when they're coming back to their country, especially when we're talking about Central Asia, they already HIV positive. For sure, I can't say about all funds, about all organizations, about all programs that NGOs have in Russia, but I could say about some of them. And I'll say about Regional Expert Group on Migration and Health. It's not resources, non-government organization. They don't have a program of real help, like services, but they have place, and you could see the link on the slide. They have place where you could find some information about other organizations, about other, in all countries in region Eastern Europe and Central Asia, and in Russia also, in different countries and different regions and different cities, different variants of help, like psychological, medical, and so on. So it's one of the variants to find the help if someone needs. And it will be a little bit a part of advertising. I will say about a foundation where I also work. And now we have a program. We have it like for 3-4 years. A program which works especially migrants, HIV migrants mostly. Not only HIV, also there are some other significant diseases. Anyway, mostly HIV. We have a lot of variants of help, counseling of the doctors, counseling of social workers, psychological help, medical help. Sometimes we provide IRT, sometimes we provide laboratory diagnostics, sometimes we provide different variants of referrals to government healthcare system organizations, like hand by hand, not official for sure. So anyway, we have such variants of help, not official, but we're trying to do it. Portrait of the recipient, it's not only about my experience, not only about our organization, it's about all country. Mostly we are talking about male gender. We are talking about people like 30 plus minus years old from the Eastern Europe or Central Asia region, mostly in Russia for sure, because I'm talking about Russia. Who lives in Russia plus minus 5 years, don't have money, don't have resources, don't have any contacts to find the help, and live with some other people in the small place. So it's like isolated person. When we're talking about migrants, especially HIV positive migrants, we're not talking about only migrants. We're talking about other key groups. And mostly migrants also have, because my experience, also have some cross groups, and mostly we are talking about MSM, male who have sex with men, but there are some other variants of key groups because of my practice. It's just for interesting slide that we have a lot of people from different countries. It could be not only Central Asian countries, but some other from Africa, from Indonesia, from South America, and from all countries of all the. And sometimes we have people who don't have any citizenship. So it's a big problem. People don't have access to healthcare system in every country because they don't have any documents. And it's a big problematic because we don't have a plan how we could help such person. Because anyway, it's not take just 1 year or years or some years before something happens. It's just no way to do something, just help for all life as we try to do. One unique experience that Russia, not Russia, correct, me and our foundation do in Russia, it's not government connection, it's there are some NGOs and STEPS fund where I'm working. We have some partnership with AIDS centers in Moldova, Kyrgyzstan, Tajikistan, Armenia, and some others. And we are trying to do a new model of work when people could register distantly in the central AIDS center in the regional region, not coming back to the country, just applying from Russia, for example, when they send some documents. And after that, after registration, after some procedure, they could have help from their country. Like they send them medicine or sometimes trying to help with diagnostics, something like this. So it's quite unique. It's not big progress right now, but there are some people, like 50, I guess, 50 people who already have distant help from their original countries officially. That's all, I guess, just contacts where we could find me, ask some questions, or I'm here anyway. Thank you.
Dmitry, thank you so much for interesting presentation. We have already several questions regarding to your presentation. So I'm gonna ask them afterwards in the Q&A session. So please stay in touch.
Thank you.
Stay tuned. Yeah, and thank you for your questions. Don't hesitate to ask them. I'm saying that to the audience. So we are continuing with the presentation by Ali Aliyev, HIV activist from Turkey. Hi, Ali.
Hi. Okay. Can you see my presentation?
Yeah, we can do that.
Okay. Oh, okay. So I'm starting. First of all, thank you. I'm really excited to be here, actually, and also thank you, Dmitry. It was such a great presentation to see what's really going on in Russia in terms of like migrants people, and it was sad to see, but it was also good to learn about what's going on in other part of the world, which I'm going to talk about different part of the world, which is Turkey. And today I'm going to talk about access to HIV care in Turkish context. And briefly looking at the agenda, what I'm going to talk about is migration and access to health rights in Turkey, HIV care in Turkey for migrants, and barriers toward HIV care for migrants, and overall conclusion and evaluation will be part of my speech. And about the speaker, I am Ali Aliyev, HIV activist from Turkey. Originally, I am from Azerbaijan, but I've been living in Turkey for almost 10 years as a migrant. And I am also one of the co-founder of the Posithiva Solidarity, which is the HIV network organization for people who is dealing with HIV. And I am currently an ESC volunteer at Posithiva Gruppen, which I'm really happy for that. So going to deep my presentation, first of all, I would like to emphasize that the HIV as a political phenomenon rather than medical phenomenon, because when it was the 80s, we were able to talk about the HIV as a medical issue because there was not a proper treatment. But in 2023, we are able to see that there's a accurate, there's a good, proper medication for HIV, but not everyone is equally accessing to the treatment or HIV care. That's why it's a political issue. And I think politicizing HIV also led us to put the responsibility to the status that they're reminding that the preventive, protective, and the treatment approach toward HIV is the responsibility of state. So that's why the states need to have policies towards the community or all the country base, especially also including migrants people. But in Turkish context, we are looking at the strategic papers or any policies about HIV. We are not able to see the migrants that are mentioned as a target group in their policy paper. And due to that reason, actually, we also see that the migrants are disproportionately affecting of HIV in Turkey. And according to many research, also my research also included to that shows that migrants are diagnosing HIV while they are living in Turkey, despite the fact that in Sweden, for example, the migrants diagnosing while they are migrating to here. It means that they have a diagnosis before coming to Sweden, but in Turkey, we are able to see that the people are diagnosing while they are living in Turkey, which again shows us that how much migrants are disproportionately affecting of HIV due to the reasons that there's no specific target groups, there is no specific information that aims to reach the migrants in Turkey. And besides the fact that the migrants people are not targeted, there's a lot of issues in terms of accessing to HIV care, but all those challenges and barriers for migrants people are affecting also by their sexual orientation, gender identity, disability, age, and migration status. But overall, to illustrate the general situation about the barriers and challenges for migrants in Turkey, I would illustrate the general situation in three different levels, as an individual level, social level, and legal structural level. And I also need to mention that all these levels are really interrelated with each other. We are not able to see that they're strictly differentiated with each other, but there's also independent from each other. That I will exemplify what I mean actually. In individual level, we are able to see that there's a lack of knowledge about HIV and HIV services in Turkey, as I've mentioned before, because there is no targeted aim for the migrants in Turkey, and there's a huge lack of knowledge about what is HIV and what is the HIV-related information, testing, diagnosing, and treatment, as well as HIV services. Also, we have a limited HIV services in Turkey with the big cities. Also, so many migrants doesn't even aware of there's HIV services that they can go, but it's also the centers are limited with only testing and having consultancy. And fear of stigma and discrimination individual level is also valid, not in just terms of HIV, but also being a migrant, being a refugee in Turkey, because there's an increasing xenophobia in Turkey, and that's why people are really avoiding to seek for healthcare in terms of facing exposing to discrimination based on their background, identity, and ethnicity. And beside that, lack of trust and knowledge and about the healthcare system is also valid, because coming from different countries to Turkey, and Turkey has a different health system, so it is hard to adapt for so many people. And also lack of trust, because the hospitals that you are going to visit, also the place that's going to report you if you get diagnosed with HIV in the system, which can affect your access into treatment. And language barriers and financial barriers is also main factors, because many migrants are really struggling with poverty in Turkey, and accessing to health, right? If you don't have an insurance, is so expensive, so not everyone is able to access. And language barriers, because in the community people are learning from each other, but in the Turkey, if you are not speaking Turkish, it's hard to be in the network, it's hard to get the knowledge about different topics in the health topics, especially in the HIV field. Come to the social levels, it is again interrelated with each other. We can see language and communication challenges again in terms of accessing to the hospital, for example, if you go to the hospital and you are not able to talk in the language that you prefer or the language that you only know, there's doctors, nurses not aware of the different languages, they don't know. And if you get your diagnosis, even you are not able to get proper information about your HIV status or the health conditions. And additional lack of community support for migrants people is also valid, and it is a two-sided actually. There is no diasporic community support, there is no any local community support. There is some organizations for refugees, but there is a differentiated status in terms of migration status in Turkey. So separatistic situation about the migrants are like migrants people are not able to get the support, but the refugees is kind of able to get support. But it is again, if they are know that there is a community, there is a civil society or angels that they can have a support, but not many people are aware of that. And culture and stigma and discrimination is also valid in country-wise, because the Turkish approach to HIV is not, there is no awareness actually, and there is no any attempt to the awareness in country-wise in the Turkey. And I want to share the picture. Actually, here it is the pictures that Health Ministry every year are sharing to as the awareness of HIV and AIDS. It's a picture of monosexist, monogamic, and heterosexist families that it says that prevention is you. And according to Health Ministry in Turkey, the prevention towards HIV is to be in a cis-heterosexist family structure, be only solution, and other solutions they are not even mentioning about. Coming to legal levels, it is one of the most important levels, because if you don't have a legal rights, other social rights is also kind of like not very important. But of course, if you have even legal rights to access the treatment, again, it's the social and like individual levels come again to as a issue in the people. And the migration status in Turkey, as a Turkey being a geographical situation to have a lot of migrants in Turkey, it also led to have a different kind of status in Turkey. So it is a very broad. So I would like to summarize and illustrate general situation in a briefly, which I would like to firstly talk about temporary protection, which is the protection types only for Syrian people. Maybe in Sweden you're already used to it because of the Ukrainian people, but in temporary protection, Turkey is only for Syrian people. And in the temporary protection, if you're under temporary protection, you are able to get the health insurance and the health system without any issue. But coming to international protection, it is another level. According to Geneva Convention, Turkey is only able to apply. I mean, in Turkey, it's only available. The people can apply for refugee status if they are coming from Europe, and it is kind of ridiculous, but it is the situation because of the Geneva Convention. Other part of the world, if people want to come to Turkey, they are not able to get the refugee status, but they are able to apply international protection. And international protection, people actually have a right to access the health rights in Turkey. Due to that reason, majorly most of the people who diagnosed with HIV are able to get the treatment, but in this situation, most of the people required to prove that they acquired HIV while they're living in Turkey. And how does that happen? They need to prove that they have also negative test result. But with helping civil society always doing some illegal paperwork, people are applying in somehow eventually able to get the treatment if they are in international protection. But coming to migrants, which is the definition base, is there who have a residency permit in Turkey, but also I'm including undocumented migrants here in this category, because all this category are not able to get the treatment or any kind of HIV care in Turkey. Looking deeply in the migrants status, which is the differentiated under the every level, we are able to see for main residency type, but I want to talk specifically two of them, which is a student residency and tourist residency. In the student residency, if you are coming as a student to Turkey, you have only 3 months to apply the health insurance in Turkey. And if you don't apply in a 3 months, you are not able to get the health insurance and of course in the free access to health system. And many students, many migrants who come to Turkey to study doesn't know all about the situation because the migration offices or the university doesn't inform about the situation to the student. So many people are not able to get their health insurance afterwards, or some people even know they don't want to make the insurance because at the one time you need to pay all the year, which is really expensive, which I've also mentioned that there's a financial poverty struggles among the migrants. About the tourist residency and people who are not able to be in the education system in Turkey, most of the people who want to migrate Turkey to applying to tourist residency, which is also available that you can prolong this tourist residency, and you can only apply to health insurance after you have 1 year valid tourist residency, which means that people need to wait to at least 1 year to be able to apply. But in all this process, you don't have to be in the hospital system because if you need to prove that you acquired HIV while you are living in Turkey, and it's very complicated. Not everyone is able to do it, and not everyone knows there's a law like that. So they are going to complement the confirmation test to hospital, and while they did that, so in the system they have stigmatized, so that's why they are not able to get the treatment afterwards. So it is the situation in general Turkey that not many migrant people are able to access the treatment here, and therefore it is sadly to say, but people are dying, as we have also seen on the Dimitri's presentation. People don't want to go back, rather than they prefer to die in Turkey, unfortunately. And according to 2021, 2021 years, the statistic we are able to say is that at least 200 people has died because of AIDS-related health condition, and one of them is Dilan. Dilan was our friend. We lost her 1 month ago almost, and we lost her because she was a trans. We lost her because she was a migrant. We lost her because she was living with the AIDS and not able to access the treatment. And Dilan was not the first one, and Dilan is not, unfortunately, not gonna be the last one in Turkey. And that's why we are, as a civil society, as an activist, working and hardly struggling, fighting for everyone to access the health right in Turkey. And it is the general situation that I would like to talk about. If you have a question in Q&A or personally, you can email me. I hope it was understanding my presentation. Thank you.
Thank you, Ali, for very interesting and also very touching presentation. I think we do have some questions for you, but as I said before, we're gonna present them during the Q&A session. Thank you so much. We are going to the presentation by Manija Megdiyar, PhD in Global Health and Migration.
Thank you very much. Thank you, Ali and Dimitri, for a very good presentation. And it was very sad, but very informative, and deepened my knowledge about migrants in other parts of Europe. So I begin my presentation here to share here first. So, it's not the beginning. Can I go just? Pardon me, I had to, the first picture here, begin here. Yeah, I'm going to talk shortly about my thesis, which is about experiencing life as migrants living with HIV in Sweden. And this thesis is based on, of course, that well-treated HIV is a chronic disease with normal life expectancy for those who are living in the countries that have access to HIV treatment, like Sweden. So the context of this thesis is migrants in Sweden. In Sweden, all the migrants have access to HIV care if they do test. The testing, HIV testing in Sweden is not obligatory, but since they choose to test themselves, they get support, and they can, if they are HIV positive, even in case they don't have a resident permit or they are a refugee, asylum seeker, so they can still have access to HIV treatment. But we know also that as a migrants, they have many difficulties and challenges. And even according to Healthy Immigrants Effect, we know that migrants are among those who have better health when they come to a new country in Western country. But after a while, after a few years, their health worsen because of isolation and other stress and challenges due to migration and migration process. Due also to pre-migration and post-migration. So we know this is the base of this thesis about migration and migrants living with HIV in Sweden. And also we know all about HIV stigma. I don't have to talk about that, but intersectional stigma. We know that HIV stigma in intersection with discrimination and exclusion due to ethnicity, racism, genus, sexual orientation, and migration status, and also more categories can worsen the HIV stigma. So the aims of this thesis was to explore the knowledge of migrants living with HIV and their life situation in Sweden, with a focus on health and well-being, as well as access, of course, to healthcare and the contact with the healthcare. So this thesis contains 4 studies. 3 of them are qualitative studies, and 1 of them is a quantitative study. So as you see here, the aim of the study 1 was to deepen the knowledge of HIV positive migrants' experiences of their encounter with the Swedish healthcare system. In study 2, we aimed to explore the experiences of HIV caregivers in providing care to HIV positive migrants. Study 3 aimed to describe HIV positive migrants' experiences of their life situation in general. And study 5 aimed to investigate whether there are differences in quality of life between HIV positive migrants and HIV positive Swedish born who receive care and treatment at the infectious disease clinics in Western Sweden, also in Västra Götalandsregionen. I don't have to go in this. The first study was published in Global Health Action in 2016. And the result of the first study shows that migrants living with HIV experience a hybrid of access and adversity. It means that they appreciated access to treatment in Sweden. They were very satisfied with their meeting in infectious clinics for HIV treatment, and the staff in the clinics, they treated them with respect, and they experience to be dignified and so on, but at the same time, they experience discrimination, isolation, and limitation among, in general healthcare when they came, for example, to a general caregivers, when they went to to dentists, when they had to go to gynecologist, and so on. So this is why this result shows a hybrid of experiences when it comes to treatment and healthcare experiences. The migrants living with HIV in this study also experience fear of Disease Act. For, as you know, in Sweden, we have so the Swedish Disease Act is about disclosing HIV to partner and also to the clinics in health care system and so on, and the study population experienced very fear, so that they were not trusted, and they were very cautious, and they were indeed very scared about this rule, the regulation, and the fact that they didn't know, they didn't have a very good knowledge about these rules, made them still more scared about this regulation in Sweden. In the study 2, which was published in Journal of AIDS and Clinical Research, was about Swedish HIV caregivers' experience of providing care to HIV-positive migrants. In this study, I had interviewed mainly nurses and social workers at the HIV clinics in Sweden. And the result of their experiences shows that these nurses and social workers experience challenges dealing with the migrants living with HIV in this clinic. And these challenges was due to migrants' migration status among these patients. For example, those who were undocumented asylum seekers, and those who had resident permit, or those who have citizenship, Swedish citizenship. So the grade of these challenges in order to support these patients, it was different. It varied, and it was differences in the difficulties they experienced to give them the support and to provide them care. One of the challenges that they experienced was, for example, lack of time for communication and support. They experienced that their time for meeting with these patients was according to the Swedish-born patients and their needs. But migrants had still more, were in more needs of communication and support in order to be able to understand the situation. They also have experiences of that migrants, the stigma and internalized stigma is bigger and much higher among migrants living with HIV compared to Swedish born. And that's why we talk about intersectional stigma. They also think that migrants don't have enough information about Swedish welfare system, and that's why they need extra resources and more because they need to understand, for example, unemployment rules, how they have to do, where they have to, whom they have to contact, and where they have to go when they get unemployed, or, for example, when they get sick. What should they do? So that's why they experience that these needs are so much that they have to have more time for communication. And also they experience that these patients, migrants living with HIV, don't have an association, patients association as well. Even for they said that even if Swedish-born are mainly connected to, for example, Posithiva Gruppen in Sweden, but these patients, because of their internalized stigma, so they are still scared to go to a place they don't know, and they have such difficulties to get related to this organization, to go there and to get their need and the support and so on. So they think there is something here to be more developed in order to be able to reach to these patients for they can get better information and they can orient themselves through the society, the new society. They also think that socioeconomic vulnerability of HIV-positive migrants is higher because of their, of course, among others, their migration status. And they think also that they have difficulties talking about sexuality with HIV-positive migrants. And that is also a challenge to them, because you know that sexuality, for example, to talk HIV-positive migrants, woman, is a little bit harder and more difficult. They think they don't want to talk about these things. So this was also a challenge they have. Social workers also experience that they have a double role. It's a gray zone because they have to give support and, for example, give talks to these patients and give them the support they need. But at the same time, they have the responsibility to do contact tracing. And these two roles, they mean, is opposite, a little bit contradiction between these roles for the patients. So the third study was.
Manija, sorry for interrupting you. I'm just letting you know that you have few minutes left, like 2 of them. So yeah, because we're having also a Q&A session in like 2 minutes.
How many minutes do I have?
3 minutes. 3 minutes.
3 minutes. Okay, then I go to the last study here, and I went a little bit. The last study was to very shortly. No. The last in the last study, we investigate. It was a register-based study, and we wanted to find out the quality of life among migrant and Swedish-born people living with HIV in Sweden, and the differences, of course. I go to the in the results shows that migrants have they say they have more side effects and compared to Swedish-born as a side effect of medicine. I go to the next. the treatment result among migrants was lower. So they had not the same positive, as you see here, a treatment result in this region we investigate. Physical health, the migrants has either very low satisfaction with physical health or very high satisfaction with physical health compared to the Swedish born. Sexual health was almost the same, but migrants had a better, they experienced better sexual health, even if there was many more migrants who didn't answer to this question. So there is a bias in the result, of course. Here you see that there were many more migrants who didn't answer the question. So because I don't have very much time, so I think I stop here, and we know that differences between equality and equity is that when we adjust the support and need to the adjust our support and research resources to the need of a specific group, instead of talking about equality, that we give the same resources. So we know that marginalized groups need adjusted support for their needs. Thank you very much. I stop here then.
Thank you for interesting presentation, Manisha. We're going to Q&A session, and we are starting from several questions to Dmitry. Dmitry, can you hear us?
Yes, I'm hearing, but unfortunately I can't use my camera. So anyway,
Okay.
I'll answer, yeah.
No problem. So the first question, what happens to migrants who contract HIV in Russia? Are they allowed to stay?
No, they're not allowed to stay. Migrants who have some infections like HIV, syphilis, tuberculosis, and some others should be deported like this. It's not like deportation, as I said, that someone hide them and go in somewhere. No, it's just like paper. Cause of it, they should come back to their country. Anyway, a lot of them are staying in Russia illegally.
Mm-hmm. Thank you so much. The second question, are the undocumented migrants living in closet taking treatment?
If they have access to some non-government organizations, or they have friends who know where they could go and what they should do, they could find some variants of help for sure. They could some organizations or funds or someone else, some people could help them. But mostly, as my colleague said, migrants don't have enough information, don't have enough resources to find someone to come. They don't know where they could come. So some of them don't have any treatment, but mostly, yes, mostly they're trying to find someone or some organizations.
Okay, thank you. Thank you. We're following the questions to Ali. This actual question could be maybe directed to all of the speakers, but what are ongoing interventions now of your work in your country to work in this matter?
Thank you for question. I would say, like, first of all, I need to mention that our organization is a volunteer organization. We are not so strong, so powerful. We are just some of the people who's doing with HIV gather and doing something voluntary. So that's why we have a limited things that we can do. But towards the intervention about this, migration issues, we have, maybe I can define two-sided. One is the right-based side, one is the need-based side. In need-based side, we are like, if the person are coming to us and telling that they are not able to get a treatment, we are trying to find a way, and like a different way. Sometimes it can be a legal way, but at least we are trying to access the people to the treatment, to the medication. So we are applying different kind of methods which we have learned from other migrants, which we have learned on our experiences. So we are trying to find a way. In a right-based approach, what we are trying to do is advocacy, that we are trying to gather all the NGOs that work in, among the sexual health, to raise our voices. Also, we are talking with some political parties and their deputies that they're raising our question in parliament, which we have done one before. And as a result, we haven't seen something yet, but we are still trying to communicate in the political parties to raise our question in the parliament. And also, as I've mentioned, like doing some campaigns, kind of advocacy process. But in the base, we are trying to be working with the people closely to at least make them access to the treatment.
Thank you so much for answering this question. Manija, would you mind me addressing this question to you as well? What are ongoing interventions now of your work in your country to work in this matter?
It's mainly about, of course, all the organizations aim to, there are now, after this thesis, there have been a few more studies that confirm the result of this study about migrants living with HIV. And I hope really that it will be more resources and more, how to say it, it's about, of course, as I said, as the result shows, more support that migrants living with HIV are needed in Sweden. And I think it will be more interventions now, because the money is provided. I mean, we have resources in Sweden. There is not a lack of resources. So it's all about willingness to want and to be able to start preventions that maybe are going to go to do good and better to make the situation of these patients better in the society as general, and in general healthcare, of course, also. So interventions are needed and resources are available. So it's about the actors to start thinking about these interventions. And I will be very happy to see that these interventions are started, of course.
Thank you so much. I have one tiny question to you, Manija, and I think that this question is going to be the last one in our Q&A sessions because we're running out of time. So you have mentioned in your presentations that migrants tend to experience more side effects due to antiretroviral treatment. May it be connected with the fact that they are still receiving old way treatment regimens even in Sweden?
A very good question. Thank you for raising this question, because we also looked in InfoCare HIV, which is a register base for all the patients, and it also contains the medicine, the medication, and which kind of medicine they get. So they receive. So we also, I also looked at all these medications, and we found out that the medication they get are not as advanced, or not as the medication that Swedish-born are receiving. And when we discussed this with infectious disease specialists in the clinics, they said that they have to do so sometimes because the status of these patients are unclear. And if they have to go back to their country, I mean, the migration status are unclear. And if they have to go to their country and they then switch to the less advanced medicine, it will not be good for the result of the medication. So that's why they have to start with these medications before they find out if the patients are going to be there. And then there is another also point I want to mention, and it's about also because side effects can be also psychological. You know, when you trust the medicine and trust the doctors, and when you are satisfied with your life, so you maybe feel less side effects. And there are research that confirm this fact that patients can feel side effects because of their how they mentally are instilled and how they think about their medication. So there are many factors for this thing.
Thank you so much. Thank you so much. At that point, we need to close the webinar. And I want to thank you, thank everyone who attended, and surely our beautiful speakers with very interesting presentations. So thank you for today, or as we say in Sweden, tusen tack för idag. Thank you so much.
Thank you very much. Thank you. Bye.
Thank you very much.
Thank you. Thank you. Have a good day.